So we know that in patients with vasodilatory shock, most of the time sepsis is the trigger. There are also inflammatory stimuli that are important, and it's a typical hemodynamic state of a high cardiac output, low blood pressure, and that acute kidney injury is a major complication of this pathophysiological state. Currently, the most common response to patients in this physiological state is to deliver fluid resuscitation. We do that because we believe that vasodilatation decreases venous return, inflammation increases extravasation of fluid, and then fluid therapy might logically compensate for the vasodilatation and the extravasation of fluid. The secondary response is the administration of vasopressor drugs. The rationale for doing that is a vasoconstriction would logically compensate for the vasodilatation associated with inflammatory or vasodilatory shock, and fluids in a significant number of patients are not enough to restore the target blood pressure that clinicians desire to achieve. Now, if you decide to give a vasopressor drug, there are a variety of agents that can be given. Norepinephrine is the most commonly used drug, but some people use epinephrine. And of course, there is adjunctive use of vasopressin therapy in a significant number of patients with a combination of norepinephrine and vasopressin. You may be aware that recently the adrenal trial and the approaches trial were published in the New England Journal of Medicine showing that low-dose, stress-dose hydrocortisone therapy increases blood pressure and decreases the use of vasopressor drugs, and that might also be now an alternative or additional treatment to deal with vasodilatory shock. But there is no convincing evidence that any of these interventions have a protective effect on the kidney. What about angiotensin II? We've kind of forgot about the other vasopressor agent. We know it's a hormone that is released in part of a mechanism where angiotensinogen is broken down to angiotensin I, and the angiotensin I converting enzyme transforms it into angiotensin II. And the angiotensin II has a variety of effects that would make sense in vasodilatory shock. It leads to increased sympathetic activity. It leads to increased absorption of sodium and fluid. It is able to trigger aldosterone production. It is a vasoconstrictive agent itself, and it is able to stimulate vasopressin secretion with water retention and the additional effect of vasopressin on the circulation. So it ticks all the boxes as an additional agent that might be useful in vasodilatory shock. In fact, angiotensin II is a member of a family of angiotensins, of which we now know there are probably about 7 of them, but these are 5 with also different effects. And so the biology of angiotensin 1 all the way to angiotensin 1 and 7 is incredibly complicated, and I will just focus on angiotensin 2. Do we have any data about the use of angiotensin 2 in human beings? Well, there is a lot of data in the literature from the discovery of angiotensin 2 about the use of bovine-derived angiotensin 2 to study the physiology of angiotensin 2 in human beings as well as, of course, in animals. And it has already been used in vasodilatory states. There are a variety of anecdotal case reports in the literature of it being used in a refractory septic shock in neonates and pediatric situations, 1 or 2 cases, potentially being life-saving. And it's been used even in a small study of the management of hypotension after spinal anesthesia, which was conducted in the 70s. However, until recently, it hasn't really made it into the clinical arena because it's kind of been difficult to have a stable, available, human-grade angiotensin II preparation that has a significant shelf life and can be shipped around the world and used safely in human beings. Do we have any data in animals and experimental models that suggest that it makes sense to give angiotensin II in vasodilatory shock? And we got into this space in about 10 years ago, and we studied what angiotensin II might do in an experimental model of gram-negative bacteremia in sheep. And this is an illustration of what might happen. You can see the blood pressure is increased by the administration of angiotensin II there in a diamond-shaped signal. You can see that the cardiac output is slightly decreased by angiotensin II, and the heart rate remains unchanged. And the total peripheral conductance, which is the inverse of the resistance, is altered, as you would expect, in a vasoconstrictive direction. As you would know, angiotensin II is a powerful efferent arteriolar vasoconstrictor, and you would expect that if you gave angiotensin II, you would decrease renal blood flow in these animals. And indeed, you can see there the RBF, renal blood flow, is significantly decreased by angiotensin II in this model of gram-negative sepsis. But of course, you would also notice that in this model of gram-negative sepsis, the renal blood flow is increased. So that what angiotensin II is actually doing is returning renal blood flow to baseline rather than causing abnormally low renal blood flow compared to baseline. And the renal conductance, the inverse of resistance, behaves accordingly. Angiotensin II appears to have some effects on the mesenteric circulation. You see that the mesenteric blood flow is slightly decreased with a decrease in conductance. It doesn't appear to have significant effects on coronary blood flow and coronary conductance in the sheep, and no significant effect on iliac blood flow, that's muscle blood flow, to the leg of the sheep compared to placebo. So it appears to be a significant, and most of its effect is on the renal circulation. It has a modest or moderate effect on the mesenteric circulation and very limited effect on other circulations. So you'd say to me, well, if you give angiotensin II to the kidney and induce vasoconstriction in this model of sepsis, what you're going to get is renal dysfunction. Well, the opposite actually happened, and you can see that displayed in this slide. When we gave angiotensin II in black compared to placebo, there was a dramatic and immediate increase in urinary output, which is really of 5 to 10-fold nature compared to placebo. So decreasing renal blood flow by causing efferent arteriolar vasoconstriction appears to potentially increase the pressure inside the glomerulus and thereby increasing filtration, and that's reflected in the urinary output and in the creatinine clearance. So even though angiotensin II decreased renal blood flow, it appeared to have a potentially beneficial functional effect. What about human beings? Did we have any pilot data that in human beings you could give angiotensin II without causing too much trouble, and that you would be able to achieve the target blood pressure and decrease the use of other vasopressor drugs? And this is a pilot study by Ming Chawla in Washington. It was conducted about 4 years ago, in a cohort of patients with vasodilatory septic shock, which were randomized to receive placebo or angiotensin II. And you can see there that the use of norepinephrine in red was significantly decreased by angiotensin compared to placebo. So the vasopressor effect applied in septic man with vasodilatory shock, and it was effective to decrease the use of other vasoactive drugs. This led to significant work in the development of a stable human-grade angiotensin II over the following 2 years, which then eventually led to an FDA-approved study for the testing of this drug and potentially leading to FDA approval for angiotensin II as a vasopressor agent in vasodilatory shock. And this was published in the New England Journal of Medicine last year. The patients were patients that had vasodilatory shock, both inflammatory and septic, and they were randomly assigned to either receive the administration of angiotensin II or placebo on top of already high-dose vasopressor treatment, because these patients had to be considered relatively catecholamine refractory at the time of randomization. This is a physiological study with some clinical correlates, and you can see there that the size of the study is moderate in magnitude, certainly nothing like what you've seen from Andy for the fluids. And you can see that you had a significant mortality in this study, as you will see, as you would expect. The patients were randomized, and therefore there was significant balance at randomization for age, gender, geographic distribution, body mass index, and arterial blood pressure at the time of randomization. These patients had a very high Apache score, as you would expect. They were very ill. They are hypoalbuminemic, and they had been resuscitated with relatively high CVP, and of course, being in a vasodilator state, a high cardiac index in the patients where it was measured. ARDS on chest X-ray was relatively common, about a third of the patients. And as you will see there, about 2/3 of the patients were not only on high-dose vasoactive medication, norepinephrine, but they were also on adjunctive vasopressin therapy, giving you a sense of the magnitude of vasodilatory state. So a very high-dose vasopressor support with a majority of patients having a septic shock. The primary outcome of the study was to test whether the addition of angiotensin II over and above the administration of norepinephrine and vasopressin would lead to an improvement in blood pressure over the first 3 hours of treatment greater than 10 millimeters of mercury and sustained for that period of time. And this was the FDA requirement to allow angiotensin II to be accepted and approved for vasopressor therapy for these patients in ICU. And you can see clearly angiotensin II is able to further increase blood pressure even in those patients that are catecholamine refractory and on vasopressin therapy. There was clearly a change, as you would expect, in cardiovascular SOFA score and, of course, a mean change in the norepinephrine use in these patients. This is a graphic representation of what happens if you give angiotensin II to these patients in blue for the period of assessment as requested by the FDA. And you can see there that angiotensin II clearly increases blood pressure compared to placebo. And then it's adjusted down by the clinicians to achieve the target blood pressure. And if you look at the ability to achieve the target, clearly angiotensin therapy is a major determinant of whether you're able to achieve the target blood pressure as you would expect. And as you might expect, previous exposure to angiotensin receptor blockers is associated with a lesser likelihood that you will be achieving that blood pressure, and quite of interest. And there's a whole literature about angiotensin converting enzyme activity in ARDS. You will see there that there is greater chance of an effect on blood pressure in patients with ARDS. This is the change in vasopressor drugs from baseline in the study group, and this is the Kaplan-Meier survival curve. Mortality was not the primary outcome of the study. This is an interesting observation that there was a trend in favor of angiotensin II, but of course this is not any proof that angiotensin II changes patient survival. And looking at adverse events and adverse effects, there were no significant difference with angiotensin II and placebo. Subsequently, this was not in the primary study. There was a lot of interest on some of the mechanisms at play that might allow us to identify responders. And as you might expect, the angiotensin I to angiotensin II ratio measured at randomization was a predictor of responsiveness and potentially a predictor of a better clinical outcome if the patients were treated with angiotensin II. And it makes a lot of sense that in patients that got a deficiency, if you wish, in the ability to generate angiotensin II from angiotensin I, angiotensin II would be expected to be particularly useful. But for kidney-related conditions, we thought we should conduct a post hoc analysis looking at those patients that were on renal replacement therapy at the time of randomization. And this was recently published this year, and it is a follow-up analysis of those very patients, because we thought that given the animal data, there was a rationale for wanting to look at this particular group and see if there was a unique or different effect of angiotensin II. And you can see there, these are the two groups. They're relatively small, about 50 to 60 patients on each side. And of course, given the small size of these two cohorts, there were some imbalances for end-stage liver disease and norepinephrine equivalent at the time of randomization. There was a striking difference, however, in terms of survival between the two groups in unadjusted analysis. And you can see there the survival in the black line was greater in patients randomized to receive angiotensin II compared to placebo. Of course, as I said, there is an imbalance at randomization, so you really want to take that with a grain of salt. But what was fascinating was that the data that was collected for this study only went to 7 days, no further, in looking at whether patients were able to recover to renal replacement therapy independence. And when we looked at the data here, again, this is unadjusted comparison on the Kaplan-Meier curves, there was a significantly greater chance the patients treated with angiotensin II compared to placebo by day 7 would be independent of renal replacement therapy. However, this is unadjusted comparisons, and therefore you really need to look at what would happen if you adjust for baseline characteristics imbalance. And when you do, you can do that in a variety of ways by looking at different models with different variables and including variables with different levels of P at univariate comparison. And you can see that according to the model, you will have different odds ratios and hazard ratios for being alive at day 28 and being alive with recovered renal function at day 7. Nonetheless, there appears to be a signal in favor of a better outcome, both in terms of renal recovery and in terms of survival in association with angiotensin II. So let me conclude by saying that in catecholamine-resistant vasodilatory shock, we now know with great strength of evidence that angiotensin II will be able to increase your blood pressure by at least 10 millimeters of mercury, and that will be quite effective. We now have a sense that amongst patients with severe AKI or renal replacement therapy, randomization to angiotensin II appeared to deliver a particularly prominent effect, and which is in keeping with animal data. And delivers what is a potentially clinically important outcome. And I think it's very likely that in the next year or two, we're going to see studies prospectively focus on this unique population to see if the findings of the post hoc analysis are indeed robust and represent a biological truth. Thank you very much.